One, this is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome everyone to a special webinar entitled The Medical and Public Health Considerations of Chloroquine and Hydroxychloroquine Use During the COVID-19 Pandemic. As we all know, we're in the greatest public health and medical emergency of our lifetimes, and the rapid transmission of accurate and evidence-based information to the best of our abilities is crucial during this time period. Next slide, please. We will be bringing a series of webinars over the next several weeks, and we have a webinar already scheduled for tomorrow on the telehealth visits to support medical toxicology practice in the time of COVID-19. This webinar starts at 2 p.m. Eastern Daylight Time, and a message about this webinar will be going out immediately after this current webinar. Next slide. I'd like to introduce the faculty for this day's webinar. Ziad Kazi is a board member of the American College of Medical Toxicology and the president of the Middle East and North African Clinical Toxicology Association and associate professor of emergency memory. Slide. Our panelists include Dr. Michelle Ruha. She's the president of ACMT, and she's also professor of emergency medicine at the University of Arizona College of Medicine. Slide, please. Dr. Bruno Megabarn, board member of MENATOX and past president of the EAPCCT. He's a professor of paramedicine and the head of the Department of Medical and Toxicological Critical Care, Paris, France. Next slide. No conflicts of interest to disclose. Next slide. The objectives of this webinar today is to summarize the current anecdotal evidence related to the use of chloroquine or hydroxychloroquine in COVID-19 infections, to describe the adverse effects related to the therapeutic use of chloroquine and hydroxychloroquine, provide the clinical manifestations and management of acute chloroquine or hydroxychloroquine overdose. Next slide. Many of you have seen the next series of slides, but I just want to make sure we're able to frame what we're under given these circumstances. As of earlier today, there were 422,000 cases reported worldwide, including almost 19,000 deaths. Next slide. This is a slide from previous slide. This is a slide from the New York Times from yesterday, just showing the countries that have been hit hardest currently. As you can see, several of the countries and Iran and the United States. Next slide. This is a graph looking at the epidemic slope by country, and as you can see, the U.S. slope is to the right of some of the European slopes, but is just as steep, indicating the explosion of this pandemic. Next slide. This is a map from the New York Times from yesterday showing that this pan-epidemic is now throughout the United States in every state, and New York is now the epicenter within the United States. Next slide. This is from the New York Times this morning, showing that the number of new cases announced each day is now over 10,000 cases as of yesterday. Next slide. And this is a count as of today by state. There are already 30,000 cases in New York. Just a couple of weeks ago, there were half a dozen cases or so. Next slide. Now, the SARS-CoV-2 virus is the seventh in a series of coronaviruses that have been discovered since the 1960s. The first two were discovered now 50 years ago, and there weren't any new discoveries until the SARS-CoV-1 in 2003 and several others in 2004 and 2005, and the MERS virus in 2012. And it's just hard to believe it's just December 2019, the SARS-CoV-2 virus. Next slide. The disease is called COVID-19, as we all know, which stands for Coronavirus Disease of 2019. Next slide. This is an interesting slide showing the fatality rate versus the average number of people immediately infected by each sick person. As you can see, this sort of data is well known with the existing viruses that are demarcated on this slide, but in terms of the new coronavirus, this is unknown in terms of the fatality rate and also the number of people infected by each sick person. The variability here is significant, as you see, and this is why, in many ways, it's very hard to predict what's going to happen over the next several weeks and months. Next slide. This is a graph from the Washington Post and Johns Hopkins yesterday showing the variability of death rates. Now, this has a lot to do with the number of people that are being tested because we don't have a background rate. But as you can see, in Italy, the death rate is astronomical at 9.5%, while in Germany, where there's quite a bit of additional testing, the fatality rate is 0.4%. The U.S. currently, at the time of this slide, at 1.3%. Next slide. The use of chloroquine and hydroxychloroquine in the treatment of COVID-19 is a emerging issue, really just days old. But given the rapid escalation of this pandemic, hospitals are rapidly adapting to this yet-to-be proven treatment for COVID-19. These are brand new guidelines from one hospital, and I believe this has been adopted at many hospitals within just the last 24 hours. What it demonstrates is that there is suggestion now that hydroxychloroquine and or chloroquine could be used in the treatment of patients with diagnosed COVID-19. In fact, the indications for hydroxychloroquine include patients with only mild severity but with risk factors, those with moderate severity, and those who are severe and critical. The suggested dose is hydroxychloroquine 400 milligrams BID times 2 doses orally for 4 days, or potentially, if available, chloroquine instead of the hydroxychloroquine. So this has rapidly come on to the recommendations at the hospital level, literally within the last 24 hours. Next slide. So where is the evidence for the efficacy of chloroquine or hydroxychloroquine in the treatment of this new virus? There certainly are no RCTs and scant clinical evidence. The evidence to date relies on the SARS experience, many expert opinion, some in vitro studies, and currently ongoing clinical trials, and many of them have just been started literally within the last hours and days. Next slide. There's several papers that have recently come out within the last several weeks looking at the early Chinese experience with the use of hydroxychloroquine. Next slide. And also reviewing the antiviral effects of chloroquine against other coronaviruses. Next slide. Quinine, or I should say chloroquine, is a form of quinine that was synthesized in 1834. Many in the medical toxicology community are quite familiar with these drugs, although their use certainly waned in recent years. For decades, it was a frontline drug for the treatment and for the prophylaxis of malaria, but due to gradual chloroquine resistance, chloroquine use has fallen dramatically in the last few decades. Next slide. Hydroxychloroquine is a derivative of chloroquine. It was synthesized later in 1946, and one of its appeals was that it was less toxic than chloroquine in animal models and also in our clinical experience as well. Of course, that is very dose dependent. It has been available and still remains on the formulary to treat a variety of autoimmune diseases such as lupus and rheumatoid arthritis. Next slide. Now, in terms of the proposed mechanisms of chloroquine and hydroxychloroquine, the research is just first emerging. There's a number of papers that have looked into possible mechanisms. Many of these include ability of these drugs to, in some way, interfere with the uptake of the virus, and also the potential for these drugs' immunomodulatory actions, particularly in the setting of some sort of cytokine storm. This is ongoing research. There's no definitive proof, obviously, of the utility or and efficacy of these drugs in the treatment of COVID-19, but this is something that we are taking very seriously as at the same time that the research is being done, the drugs are being introduced rapidly into clinical practice. At this point, I'd like to turn the presentation over to Dr. Kazi, who will introduce the next panelist.
Thank you, Dr. Wax, for providing this useful summary of information that we have so far. I wanted to ask Dr. Bruno Megarbin, who is located in Paris, France, to share with us some of his current experience treating patients infected with COVID-19, with the disease COVID-19 in his intensive care unit. Dr. Megarbin.
Thank you, Dr. Kazi. So just a first word to tell you that the situation in France is currently very critical. We have about 3,000 critically ill patients in our hospitals, while the capacity of admission is about 5,000. So we are approaching the limits while we are still at the down part of the curve, and we have about 1 week and a half with delay to Italy. So as explained by Paul, this infection is severe with about 15% cases of severity and an elevated fatality rate, probably higher in Europe than was reported in China. And treatments include antiviral and immunomodulatory drugs proposed to control the viral replication and to regulate the immune response. And as said to date, there is no definitive therapy that has been proven effective. So encouraged by experimental data shown by Paul assessing the ability of hydroxychloroquine in vitro to reduce the viral load, and based on some very preliminary clinical observations from China suggesting the superiority of chloroquine versus control to inhibit the exacerbation of pneumonia, a French study conducted by Professor Raoult, which was a non-randomized open-label trial, showed a decrease in viral load and carriage duration in COVID-19 patients receiving hydroxychloroquine 600 milligrams per day during 10 days. The effects of hydroxychloroquine were enhanced, as shown on the slide, when combined to azithromycin. This study was published last week in a journal of antimicrobial agents, but in parallel there was a huge buzz on internet since these scientists communicated on YouTube saying that the hydroxychloroquine is efficient to treat the patients and recommended physicians to deliver this therapy to all patients, including those with minor symptoms, aiming to avoid them to go to the ICU. The problem is that the study findings were, of course, considered as remarkable and promising by some scientists, while they were questioned by more skeptical due to major study limitations, including a small sample size, no intention to treat analysis, no analysis of clinical benefit, and short follow-up. But due to the pressure of the population and the physicians who were desperate to treat the patients, they started to prescribe this off-label drug. So in our ICU in Paris, we have an experience because we treated about 15 patients with the combination of hydroxychloroquine and azithromycin. All these patients were admitted in our department for IDS, So we aim to prescribe this therapy before the prescription of corticosteroids, aiming to control the viral replication before giving the immunomodulatory treatment. So, of course, I have no possibility to give an objective answer regarding the effectiveness of this therapy. First point is this treatment is not miraculous. There is no clear reduction in the viral load, but of course we have no control to compare to it. And secondly, of course, this therapy allowed us probably to give steroids in the majority of these severely infected patients. Until now, among our 15 RDS who are intubated and mechanically ventilated, 2 of them were extubated at day 7 and day 8. So in the majority of these patients, the RDS is prolonged and the treatment is complicated despite the prescription of these antiviral therapies.
Thank you, Dr. Megaban, for this really important update and perspective from France. We hope that the situation in Europe will ameliorate very rapidly, and we also hope the situation in the U.S. will also improve in the future. Now, certainly with this information that is available online and through multiple routes of communication, in the U.S. as well, we started thinking about these therapies. And as the American College of Medical Toxicology was, following this information, we saw news from Nigeria where there were records of chloroquine poisonings by people using these for COVID-19 prevention or treatment. It wasn't clear to me from the report, but certainly there was an announcement by the Nigerian National Center for Disease Control about the hazards of poisoning. This was followed in the U.S. by this incident that occurred in Arizona that I would like to ask Dr. Michelle Ruha, who actually in Phoenix, Arizona, to share some information about this specific incident. Michelle Ruha?
Statement in the United States about the potential for chloroquine and hydroxychloroquine, and it's been in the press quite a bit. And shortly after, there was a press release about using chloroquine and hydroxychloroquine for this. There were 2 people in Arizona who saw a story on the news about it and then recalled that they had some fish aquarium disinfectant that is actually chloroquine phosphate. They had this in their home. And Ziad, if you go to the next slide, I think we may have some information about that. So I had not heard about fish aquarium disinfectant containing chloroquine, but it turns out that others have, because the sales had skyrocketed prior to our cases here, and the cases here actually had already had this on hand, but it really highlights that right now all of these aquarium products appear to be sold out, and there was an article that described them selling for up to $500 for relatively small amounts. So this is actually, as far as we can tell, like just chloroquine phosphate, possibly 100% chloroquine phosphate, and large quantities in powdered form. And so the 2 people that were here took the product, ingested about a teaspoon, maybe a little bit more than a teaspoon, which we estimated to be between 5 and 10 grams, maybe 7.5 grams about, in an effort to prevent coronavirus. And as has been well reported, one of the people died, and the other one survived. And I think that's very consistent with what you see in the literature. People can take similar amounts, and even high doses like that, if there's early vomiting, that tends to be protective, and the patient who did well had a lot of early vomiting as opposed to the patient who died. If you go to the next slide, I think we have another slide on the product. But so we were just concerned that there's obviously a lot of people who have been buying up this chloroquine phosphate, and I don't know who they are, but our fear was that more people would start trying to self-medicate. So we did want to warn the public not to use this product or really self-treat at all, whether it be medications or this powdered form that seems to be available.
Thank you, Dr. Ruha, for sharing this update from the from Phoenix, where these patients lived and cared for. Of course, you raised excellent points about the narrow therapeutic index of chloroquine and hydroxychloroquine, and the possibility of adverse effects, even potentially lethal effects, at therapeutic doses, supratherapeutic doses, and in overdose. And certainly, different patients will have different individual characteristics, including their genome and metabolism, as well as other medications they are on. Concomitant therapies are an important factor here to consider. Certainly, their kidney function, their liver function, the dose that they were using, and then the duration of therapy, and whether it was hydroxychloroquine or chloroquine as well. Reportedly, chloroquine is more toxic than hydroxychloroquine. I think the major effects that we see in an overdose situations can be looked at through the blockade of sodium channels, potassium channels, as well as the shift in the potassium into the cells. And we will talk about some of these clinical manifestations in a few slides. But I think keeping in mind the interpatient variability and the risk assessment here is necessary when managing these patients. The organ systems that can be affected at therapeutic or supratherapeutic or even overdose situations are varied. The cardiovascular system is certainly a major organ system. The gastrointestinal one is the most well known to be linked with these quinine derivatives, and we call that the synchronism part of it, the GI disturbances that occur. The central nervous system is affected with people having a variety of central nervous system manifestations. The hearing and the vision, those are important. We'll talk about those separately. And of course, we see some rare reports of myopathy, neuropathy, endocrine problems, hematological problems, particularly in the G6, in the patients with glucose 6-phosphate dehydrogenase deficiency. They can develop hemolysis when they are exposed to these drugs. Some of the side effects or adverse effects I would like to just focus on a little bit more include the cardiovascular effects and the QT prolongation. As you know, the QT interval is affected by the potassium channel blockade here with the hydroxychloroquine or the chloroquine, and you do see these QT prolongations, the presence of U waves. Now, this patient that you see here is not a chloroquine overdose. This was another type of overdose of potassium channel blocker, but you do see here the QT prolongation and the U waves that are obvious on this EKG. The vision is affected usually with therapeutic use for a long duration as well as of a large dose. So the importance of a cumulative dose here is to be noted. What you see on this retinal image is the bullseye maculopathy, which is unfortunately a late finding, and at this point is irreversible even if you stop the drug. That said, care should be taken by assessing patients on these drugs for visual effects, which may not be very apparent at the beginning. It can be quite subtle. So, working with ophthalmology on monitoring these adverse effects is important. Same with the hearing, where you do see sensory neural hearing loss. I want to point out that the visual loss can occur in an acute overdose as well, although it is usually transient, but certainly can occur in an overdose setting. The myopathy and conduction blocks, those occur usually with therapeutic use and can occur suddenly. And we don't really understand exactly why they occur, whether they're a type of hypersensitivity reaction. But if you notice your patient develops a conduction block, like a left bundle branch block or a right bundle branch block or a complete AV block, or whether they develop some other findings, you need to look out for this adverse reaction. And also look for myopathy, which can, of course, present in its own way and can be diagnosed clinically and using echocardiography. Now, in an acute overdose, you do see some exacerbations of the conduction effect that we mentioned initially. And here, this is a patient that I took care of in 2015 in the state of Georgia, where we have widening of the QRS and flattening of the T waves. This was an acute overdose of hydroxychloroquine at the time. And the wide QRS is an important finding along with the QT prolongation and the U waves. And this is often accompanied by a sudden collapse, cardiovascular collapse. This is why you see these patients develop their severe toxicity quite rapidly in an overdose situation. Before we move on to the actual management of these overdoses, I would like to bring in again Dr. Ruha and Dr. First, and then followed by Dr. Megarban. Dr. Ruha, your cases, and I know you may not be able to share a lot about your cases, but are you able to share if it was consistent with what we discussed so far?
Yes, and I'd just also like to bring up that there's an excellent study in the New England Journal of Medicine from 1988, which I don't know if this will be brought up separately, but it really talks about, some of the predictors of mortality and the wide QRS, especially a QRS over 120 milliseconds, and hypotension, and the dose ingested can be, very predictive. But yeah, I think someone who's going to do poorly, a wide QRS is a key indicator early on.
Certainly, the low potassium also is an important finding. The cases that I've had a couple of cases, 2 cases in my career, and they had severely low potassiums below 2 milliequivalents per liter. And like I said, this is usually thought to be a shift of the potassium inside the cell, but it's difficult to manage because of its potential reversible nature, and then is prognostically linked with severe outcomes. And, interventions with potassium replacement can be tricky here. So I don't know, Dr. Megarban, before we talk about the acute overdose management, I wanted to bring you back to your patients. Obviously you have quite a bit of experience in this therapeutic setting now in Paris. Are you seeing particular adverse effects from these drugs, and what are you doing to monitor for these? Is there a specific protocol that you are implementing on your 15 patients?
Yes, as you said, despite hydroxychloroquine is probably less at risk of cardiac toxicity than chloroquine in treated patients, both drugs and even hydroxychloroquine represents a challenging threat in the ICU patients who are treated with hydroxychloroquine, even for a very short period. There is an increased risk of toxicity due to drug-drug interactions, to underlying cardiac morbidities, and to acute kidney injury that are observed directly in relation to COVID-19 infection. So there is really a risk, and of course in the ICU it is quite possible to monitor by daily or twice daily ECG and to measure the hydroxychloroquine plasma concentrations. Till now, we mainly observed prolongations in QT in almost all the patients, and we have to stop the therapy in at least 3 patients till now on 15. So the recommended dosages of hydroxychloroquine in your recommendations are probably too high or at risk in ICU patients at least to be responsible for QT prolongation. That's why the national health authorities in France did not support the prescription of hydroxychloroquine in outpatients, especially if it's associated to azithromycin 2.
Wow, this is fascinating. May I ask you what QT measurement you are using to stop the therapy, or are you using QTC by Bazet?
We are currently performing a study to see which formula of QTC measurement is the best, but we use the Bazet till now. But of course, I know that you published with Dr. Ritrak Otong an article on the best way to measure the QT in drug-induced prolongation. I have to tell you, I don't remember the name of the formula, but yeah, I know that you said that it is not Bazet.
Well, I was asking to see what measurement. So would you use a 500 millisecond measurement as a cutoff to stop the therapy?
Yes.
Okay, thank you. This was my question.
So in the patients we stopped the therapy, QTC was longer than 500 milliseconds.
What about the ophthalmological monitoring? Are you working with?
No, we are not monitoring because the patients are all of them are sedated with muscle paralyzing drugs, so it's impossible to monitor the ophthalmological side effects. But anyway, those effects are probably expected to occur with prolonged prescription. So it is not really the issue in the ICU patients treated for 5 to 10 days with this hydroxychloroquine.
Very good. Thank you so much. Now, moving next to the management of these acute overdoses, I know that this management is quite complex and, of course, is based on proper risk assessment. Trying to estimate the dose that was ingested is important, especially that doses more than 5 grams, for example, of hydroxychloroquine are certainly serious ingestions. And taking into account what Dr. Rua said, that there are inner patients variabilities, and especially the patient vomited and may have ingested less. But certainly an aggressive support care is key here with early intubation and, making sure you're ready for the deterioration that can occur rapidly. And using in this area some of the experience from that goes back many years with these overdoses that have occurred for many years. We know that high dose epinephrine is certainly recommended. Epinephrine, as opposed to other vasopressors, has been studied, and at high doses, it's been recommended. Which is a benzodiazepine that is recommended also doses. The first case that I had in 2003 with my colleagues at Emory, we actually exhausted the supply of diazepam because I believe 2 milligrams per kilogram bolus which was about 120 milligrams in that before, and then we were giving 50 grams per kilogram per day for 3 to 4 days. And you can do the math and realize that your hospital will run out of diazepam quite rapidly. I know for a fact that we were very unpopular amongst our pharmacy colleagues at the time. The less straightforward management strategies, I think, include sodium bicarbonate. When you see a wide QRS from a sodium channel blockade, your first reflex is to go and get the sodium bicarbonate, which is supposedly going to decrease the sodium channel blockade by the chloroquine or hydroxychloroquine. However, in the setting of hypokalemia that is occurring here, you worry about exacerbating the hypokalemia and the effect on the QT interval. So, although it's been used, you have to really assess the risk and predict where you are with the potassium level and whether the potassium level or the QT prolongation is going to be part of the problem here in the care of this patient. And I'm looking forward to discussing this with colleagues during the panel where I hope people will send chat questions because we are going to mute everybody. But please send as many chat questions to the host, that is me, and we will go through them one by one. Now, potassium replacement is another thing that is interesting. As we said, it is supposedly transient, and it is a shift inside the cell. So if you correct rapidly initially, you may end up with a hyperkalemic situation. And although low potassiums have prognostic value, they do not end up leading to the cardiac arrhythmia and death, according to many experts who reported their data in various studies. But still, a potassium replacement should be considered, especially with severe hypokalemic situations. I know with our case, our potassium was 1.5, and the second case it was 1.9. In these cases, you want to replete. I remember the issue we had with the first patient was that we wanted to give a very large amount of potassium, and of course, our nursing colleagues were hesitant to do that because we were trying to give over 100 milliequivalents of potassium in a short period of time by central line. So it's not a straightforward action, and needs to be planned and executed carefully when you have these patients. And again, I look forward to comments from my experienced colleagues on this call. But moving away from the management of these acute overdoses, I think it's important for us as well, since we are all involved in public health practice as toxicologists and healthcare providers in these times. We want to think about what are the relevant public health considerations during a pandemic to the use of hydroxychloroquine and chloroquine. I think some of the issues that come to my mind, at least, are the lack of clinical guidelines for the off-label use in COVID-19. That's a big problem. I think having clinical guidelines that are properly vetted and properly developed is important, and unfortunately, it will take a lot of time and effort to do that. These guidelines should look into vulnerable patients, including healthcare providers. I would like to include us as vulnerable patients and other vulnerable patients, whether it's because of their comorbid conditions or their age. We shouldn't forget about our emergency responders who are, transporting some of these critically ill or severely ill patients to our hospitals. What do we do in special populations with children, pregnant women, those that are breastfeeding? And how do we look at drug-drug interactions? Specifically if we're planning on using azithromycin, for example, or another drug that we know interferes with the QT interval or has an interference with cytochrome P450 that are also involved in these drug metabolism. Thinking about the ability to monitor for these adverse effects during an emergency. I know Dr. Megarban is monitoring really well in the intensive care setting his 15 patients. But if we're looking at this as a public health measure, this therapy is a public health measure being given to thousands of people potentially, how do we monitor for these adverse effects? Are we able to monitor the QT? Are we able to look at the electrolytes? Are we able to look at the liver function or the kidney function? What about other target organs that are affected? That's certainly not a simple task for our public health system to accomplish. And with the limited supply of these pharmaceuticals and with the limited prescribing rules, there is a concern, a serious concern that we raised together at ACMT and the EAPCCT and MENATOX of the potential risk of people seeking out alternative non-pharmaceutical formulations like we saw in Arizona. And this is really why we felt an urgency to get this program to you rapidly, as we did. This is literally a project that was born on Monday morning, and we were able to get it as best as we can. Nothing is perfect, but this is the best product we were able to get in 2 days. Now, I hope we can discuss some of these public health considerations together today with the Q&A session. I hope that you will type your questions using the chat and sending them to the host myself. Again, in summary, chloroquine and hydroxychloroquine are currently used for malaria, and also hydroxychloroquine is used for rheumatoid arthritis and lupus. We are seeing them also being used for COVID-19 infections, whether they are part of an off-label use or part of a research study like we see in China, where there are 23 clinical trials that are ongoing right now looking at this. Of course, both drugs are associated with several adverse effects affecting the heart, the gastrointestinal tract, hearing, vision. We can also see effects on the including myopathy, neuropathy, neuropsychiatric events, and hypoglycemia. For that, I invite you to consult the label that is approved by the Food and Drug Administration that is posted on DailyMed that lists these adverse effects. And remember, in your acute overdoses, those that can be severely dangerous with severe toxicity in different organs or systems. We know the heart is a major one, the brain, and of course, looking at your potassium and managing that appropriately. With that, I'd like to thank you for your attention, and I look forward to a fruitful discussion in the Q&A. Thank you.
Well, thank you, Dr. Kazi, for a wonderful presentation, and Dr. Rua and Dr. Maraband. We have many, many questions that have been queued up, and I'd like to start to ask the questions of the faculty and panelists, and we have another 20 minutes or so on this webinar, but we could go longer if need be. There are over 600 people on the webinar currently. One of the questions that came up is about the use of these drugs in an outpatient setting, and the concern really is about the availability of the drug. There's a critical shortage of these drugs, and at this point, many of the hospitals are just preserving these drugs for the sickest patients, and that's the patients that are hospitalized. And for that reason, I think predominantly there's been strong recommendations against the use of these medications in an outpatient setting or for any sort of pre or post-exposure prophylaxis. So with that in mind, I can start to thumb through these questions, and we'll start off with question about the diazepam dosing. Ziad or any of the others, would you like to comment about the exact dosing recommended in the acute overdose setting?
Sure. I think the dose is recommended. I'll take that question. The dose recommended is 1 to 2 milligram per kilogram IV over 30 minutes, followed by, actually it's 2 milligram per kilogram IV over 30 minutes, followed by 1 to 2 milligram per kilogram per 24 hours for 2 to 3 days. And this is coming out of one of our toxicology textbooks.
Okay, and the next question, particularly as it relates to the QT prolongation, about the addition of the azathioprine, the combination of the hydroxychloroquine and azathioprine, does this increase the risk of some sort of arrhythmia?
Do you mean azithromycin?
Azithromycin, yes.
So
oh, go ahead.
Go ahead if you can. Go ahead.
No, I was just going to say, actually, I think, yes. The problem is that people may be, in addition to having the risk of QT prolongation just from the hydroxychloroquine or chloroquine, many people may be taking other QT prolonging drugs. And yes, the combination of hydroxychloroquine and chloroquine with any other drug that can cause QT prolongation would increase the risk. And if people in the hospital are sick with COVID, they may have cardiac toxicity and other things that are also predisposing them to QT prolongation. So I think that is something that we're going to need to be watching for very carefully in people that are receiving this regimen.
And I add to that, Michelle, that the review paper on this topic, and this paper actually shows that reports a study that was done, hydroxychloroquine and azithromycin. This was being done for malaria treatment. And they wanted to look at the QT prolongation in patients that are taking antiemetics. And they actually, that they had STDs and they were being treated with azithromycin. And they did give these patients both drugs. And there was a significant prolongation in the QT interval and the QTC by Bazette. Then there was another study in animals that study in animals did not show an increase compared to just being on chloroquine alone. But this study is available online. I can potentially send that to you if you're interested.
Next question is, are there any recommendations regarding the use of hypertonic saline or chloroquine-induced sodium channel blockade?
That's an excellent point because of the hypokalemia and the ability to give the sodium load without affecting the potassium. I looked for this in PubMed this morning and I could not find it, but certainly something that I would consider if I'm about to give bicarbonate in a patient whose potassium is low or about to get low.
Okay, great. Next question is about what happens if the diazepam supply is exhausted? Is there a role for other benzodiazepines such as midazolam or lorazepam?
I remember looking at these papers when we had our case in 2003. We reviewed the papers on this. Many of them are in French because of the use of this in Africa and Francophone countries. And there is a benefit, a theoretical benefit with diazepam, with receptors in the heart, as well as effects of diazepam on the binding of the chloroquine. So there are some theoretical reported benefit of diazepam specifically. And I don't think this benefit is been proven for other benzodiazepines, but I understand the shortage is a problem. Like I said, we exhausted the supply of the hospital in an overdose setting. Again, this is an acute overdose setting where you need this. I don't know if, Bruno, you have any other things to add to this. I think Dr.
Well, I'll add that we already have diazepam shortages, and we would not be able to give that. So we would be using other benzos as an alternative. I think that's what you have to do if you can't get diazepam.
Ziad, can I comment?
Please.
Yes.
Yes. So in France, we have a large experience with chloroquine poisoning. As I said previously, hydroxychloroquine poisoning is less severe than chloroquine poisoning. But we have a large experience with chloroquine because in 1982, there was a publication of a book called Suicide, How to Succeed Guide. And this book encouraged the depressive people to ingest chloroquine to complete their suicide, because at that time chloroquine was sold in the pharmacy in packs of 4 grams without a prescription. And following the publication of this book, there was a huge increase in the number of suicides in France, mainly due to chloroquine. And based on this experience, we defined the management of chloroquine poisoning. We first determined the prognosticators, and an ingested dose of more than 4 grams, or a systolic blood of less than 100 millimeter of mercury, or an enlargement in QRS of more than 100 milliseconds, are associated with the risk, an increased risk of death. So in the presence of one at least of these conditions, the patient should immediately be intubated and mechanically ventilated and receive epinephrine infusion and diazepam. This work was published in the New England Journal of Medicine in 1988. It has showed that this management, this immediate management, in comparison to the administration of treatment only based on the onset of the different symptoms, has saved life significantly. So, to my opinion, the most important part of the treatment is intubation and epinephrine administration to avoid bradycardia. While diazepam was at that time included in the protocol because there was some observational studies in Africa by the military doctors, the French military doctors in Africa, where chloroquine poisoning was relatively frequent, and they observed that those who simultaneously ingested chloroquine and diazepam have a better prognosis than those who ingested only chloroquine. That's why diazepam was included in the initially published protocol. But in fact, probably the role of diazepam is relatively minor. I'm not sure that this is important. But in fact, it seems that diazepam has an effect that no other kind of benzodiazepine has. The mechanism, as you explained, is not quite understood. But to my opinion, if there is any shortage in diazepam, there's no problem. The only important part is intubation and epinephrine to avoid the risk of ventricular arrhythmia onset.
Thank you, Dr.
Of course, with hydroxychloroquine, the risk of such severe acute overdose is less important. The risk of intraventricular blockage is less important than with chloroquine, and the major side effect is QT prolongation.
Dr. Megarban, can you comment a little bit? A question came through. What is the evidence for azithromycin, adding azithromycin to the chloroquine or hydroxychloroquine?
Yes. So azithromycin has an immunomodulatory effect and also an antiviral effect in vitro. So it was added to increase the antiviral effects of hydroxychloroquine, especially that in the majority of the patients when they are admitted to the hospital with pneumonia, with symptoms of pneumonia, they are treated with a combination of penicillin and macrolide. So it's better to choose azithromycin than any other macrolide because of these antiviral and immunomodulatory effects that were previously known in the literature.
Thank you. And then,
thank you. So additional questions. We have quite a few still in the queue, and we'll try to get to as many as possible. But the question is, if a patient presents with COVID positive with some sort of cardiac problem, such as a STEMI or cardiomyopathy, would you suggest avoiding the hydroxychloroquine as a treatment regimen?
No, I would not suggest to treat them with hydroxychloroquine. I think if the patient has previous cardiac morbidity, or if he presents cardiomyopathy or myocarditis in relation to COVID, I will not prescribe hydroxychloroquine, especially that its effectiveness is still not proved.
Okay, thank you.
Sorry, Paul. One of our participants is asking, how do you measure the viral load in your patients with COVID-19?
So it's RT-PCR. So it's the same technique than the screening of the patients. But when you screen the patient with this technique RT-PCR, the major response will be positive or negative. But you will do a number of runs to obtain the positivity. So this number could be assimilated to the viral load, even though it is not exactly the viral load, because the exact relationship between the viral load and the number of runs to obtain the positivity is not quite established, but it's constant with each method used, with each technique. So it is now used to calculate the viral load, but probably later after the crisis, there will be more studies to exactly correlate the number of runs and the viral load. But one important point to know is that all these techniques, which are based on RT-PCR, will evidence the presence of RNA, which does not mean that the virus is viable. So till now, we are talking about a decrease or increase of viral loads, but we have no evidence that the virus is still active and alive. And this requires viral cultures, and of course, during the crisis, it's impossible to do such studies because it is very long, but all these viral cultures will be done later on.
Thank you.
Okay. Great. Another question, does anyone have any experience or know the data about the efficacy of intralipid in the management of some life-threatening overdose with either of these derivatives?
Yes, in Paris we treated several cases of very severe chloroquine poisoning with intralipid. In my experience, there was no effectiveness. The only recommended treatment is ECMO in the case of life-threatening situations that do not answer to sodium bicarbonates and to increasing doses of epinephrine. And we used to implement ECMO if the required dose of epinephrine is more than 3 milligrams per hour in the presence of organ failure, respiratory or renal failure. In our experience, all these patients will die if ECMO is not performed.
Okay, great. Thank you. Next question is, beyond the patients with the cardiac comorbidity, are there other groups of patients at risk that you would not provide the hydroxychloroquine to?
I think we have to perform a preliminary ECG to measure the QT, and if the QT is non-prolonged, if the patient has no previous cardiac morbidity, if there is no other combined drug that may increase the QT, then we can prescribe it. If, of course, the patient is closely monitored by daily ECG and probably by the measurement of the concentration of hydroxychloroquine. But the problem is that the majority of the patients, and at least those we saw in the ICU, they are relatively young, 55 to 60 years old, and almost with very mild comorbidities. And so they are almost all of them able to be treated with hydroxychloroquine.
Okay, great. Thank you. How about any recommendations regarding hydroxychloroquine in pregnancy?
I think it is quite possible to use it in pregnancy, but of course, in this setting, we have to be cautious. We have one pregnant woman in our ICU. She's infected by COVID, and she has now her pregnancy is at 28 weeks. So she was admitted before the publication of the French paper regarding the possible effectiveness of hydroxychloroquine. So initially we did not give her this medication and rather treated her with the association of lopinavir and ritonavir, which also is possible in pregnant women. And now her situation is improving. We did not have the necessity of taking the baby out of her, so hopefully she will her outcome will be good in a few days.
Okay. And another question about for patients taking any 2D6 or 3A4 inhibitors, are you adjusting the hydroxychloroquine dosing?
Of course, this is also an important question. We are monitoring the concentrations, and of course, majority of these patients receive mainly sedative drugs and antibiotics, and almost no other drugs. But we have to be careful, of course, if there is any potential interaction with cytochrome P 450.
Paul, there's also, thank you, Dr. Megraban. There's also an interesting question I would like to just highlight, asking about the fish tank cleaners. In light of increased sales of fish tank cleaners with chloroquine, should public health officials responding to the COVID-19 crisis message appropriately regarding the risks? And I certainly think that the answer is yes. Actually, believe also that the AAPC, the American Association of Poison Control Centers, as well as the Centers for Disease Control and Prevention, working on monitoring these products that come to the poison center. Messaging needs to be done, similar to what's been done in previous public agencies. And I think at the state and local level, this is an important reminder. I see that states and locals are about the prescribing of these drugs. I think also messaging about the risks of alternative non-pharmaceutical compounds should be done.
Okay, and I think we'll have to wrap it up. Last question back to Bruno, just again about the dosing of the hydroxychloroquine. Bruno, could you once again explain your dosing regimen?
So we use the dosing regimen recommended by the French researcher Professor Didier Raoult. So we administer 600 milligram per day. So that means 200 milligram 2 or 3 times during 10 days. But we noticed that the concentrations are the plasma concentrations are relatively high with this regimen.
Okay, thank you.
At least higher than the concentrations measured in patients treated for a long time for dysimmunity.
Okay, thank you. Any final comments from the panel or Ziad?
No, I want to thank Dr. Ruha, Dr. Khan for making themselves available at such a short notice. I also want to thank the EAPCCT, the ACMT, and MENATOX for this collaboration, and hope we can have additional collaborations together and with all other professional societies in the coming weeks to as we face this pandemic.
Yes, thank you. And I just want to wish everyone the best of luck and to be safe and to bring forth further suggestions using our virtual facilities. As you can see, we can do very important communications on an international level on a very quick setup basis. And so please bring forth ideas and suggestions, and we'd be welcome the idea to facilitate any future sessions. Again, thank you very much. Your comments have been very much appreciated. Some of the comments that we didn't get to are wonderful ideas that we will take back and address in the very near future. This webinar has been recorded and will be available up on the ACMT website, hopefully within the next 24 hours. Thank you very much.
Thank you.